Well, it's time to start this parallel session. Good afternoon, everybody. My name is Marco Blom. I'm Scientific Director of Alzheimer Nederland. I'm also a board member of Alzheimer Europe. And I must say I was proud co-host of the last year's conference in The Hague, which will be a historical conference, in my opinion. And not only by the high numbers, but also by the fact that it was a traditional conference. Probably from now on will be used to at least a blended conference in which online is a big part of a conference. What we will do is that we have 5 pre-recorded presentations. They will last about 12 minutes each, some less, some more. If there's any question and time left, then I will give the floor to one of the questions. You should ask these questions in the chat of the Zoom, because that's one of the typical problems we have, is that we cannot ask questions by the platform of the conference, but you need to use the chat of the Zoom application. So please take care of that. And I will shortly introduce the speakers and then give them the floor. As I said, we have 5 presentations, and I think they cover the whole theme of assistive technology very nicely, from implementation and successful implementation onwards new developments. And I think this time era of COVID has proven to be a very important context for assistive technology. So we should keep the best for the future, I hope, COVID. But we have to learn today from these examples we will be presented by the speakers. So I will start giving the floor to Henriëtte van der ROEST. She is head of the program of aging of the Trimbos Institute in Utrecht, the Netherlands. And this program aims to improving the quality of care of people with dementia and persons with psychiatric problems. And I would like to mention that Henriëtte is also a member of the Task Force Assistive Technology of INDUCT.
Okay, thank you, Marco, for your introduction. I will try to share my screen. I hope it will work the first time.
Welcome. Thank you for attending the session on factors influencing implementation of assistive technologies for people with dementia. My name is Henriëtte van der ROEST. I am head of the program on aging at the Trimbos Institute in Utrecht. The study was initiated by members of the Task Force Assistive Technology of Amsterdam, and I'm presenting also on behalf of them. Well, we see an increased interest in the application of assistive technology in healthcare because it has advantages. It's easy accessible, it has personalization options that makes it possible to provide customized care. It's also more fun when the application is working, and it can reduce resource use in terms of cost and staffing. First of all, we see this increased interest in, well, all the amount of literature that's being published on technology and dementia. As you can see by this easy PubMed search, the numbers are rising exponentially at this moment. But there's also international research programs like AAL, but also international stimulation programs that stimulate uptake of technology. And we see a lot of multidisciplinary collaborations with projects involving engineers, designers, developers, but also clinical and social researchers. From the literature, we know that there is a lot of positive effects of AT in dementia. So for people with dementia, it can help to improve or maintain their cognition or help them in conducting tasks, but also for participation in enjoyable activities. For informal carers, the use of technology can provide a feeling of reassurance and decrease burden, but it can also improve application of technology for professional carers in dementia care can enrich their knowledge on dementia. It also improves the readiness to change and makes professionals more receptive to training. But yet we see a low uptake of technology in dementia care. And that has to do with a lot of different areas. It can be due
This would be on video, okay? So we're listening to, not on the video at the moment, so just leave it, but you can listen.
To do with implementation strategies. A lot of studies have been conducted on technology development, and we wanted to use those studies to explore what factors influence the successful implementation of technology or unsuccessful implementation of technology, for community dwelling people with dementia in Europe that targets improvements of social health. We draw this study on expert opinion. So we invited 206 INTERDEM members to participate in the study with the requirement that they had to be involved in technology projects in the past or in the present. We developed one online survey with 2 versions. The survey was based on what we know from literature that are factors that contribute to implementation or are barriers to implementation of technology. So we ask questions from characteristics of interventions, characteristics of the development process until the implementation process. So we ask about the descriptions and aims of the interventions, but also about user-friendliness, usability, which studies were performed along the project, but also about cost and financing. We had 21 valid responses back. We know that 32 INTERDEM members declined of participation because they were not involved in any technology projects. And we know that the survey was forwarded to at least 30 other persons. The respondents were from 7 European countries and also 1 from Hong Kong. And most of the respondents worked at university and few of them worked in a clinical setting. So if you look at the characteristics of the interventions and of the response we retrieved, we got answers of 12 projects that were successfully implemented in practice and 9 projects that were not successfully implemented in practice. And first of all, we looked at the aims of the interventions that were targeted by the technological intervention. And therefore, we used 3 domains of operationalization of social health for dementia. So to fulfill one's potential, management of everyday life, and participation in social activities. And what you see in a blink of an eye is that most of the interventions were developed to help people to manage everyday life. What we also see is that personalization options were not included in the interventions to a large amount, slightly more in successful projects than in unsuccessful projects. But a big difference is that the intervention is affordable to everybody for successful projects and only in 2 out of the 9 unsuccessful projects. We asked the respondents to indicate from a list of 30 teams whether they thought the theme or the area was a facilitator or a barrier. And so what you see is that in the area of types of devices and user-friendliness were the most mentioned facilitators for the implementation of technology, but also single, multiple device use. And the type of device and user-friendliness were also named as the most frequently named as barriers of implementation of technology. And there's a range of other areas that also are seen as barriers or facilitators, like but also internet connection, the financing, etc. Well, the most used device in the studies we retrieved was a personal computer. So from the 21, 12 were running on a personal computer. And in successfully implemented projects, 75% of the projects were running on a computer. Next to that were tablets. Almost half of all the interventions were running on tablets. And the third named device was smartphone. And more successful than unsuccessful implemented projects run also on the smartphone. What is important is that interventions can run on multiple devices. So almost all of the successfully implemented projects run on multiple devices to slightly more than half of the unsuccessfully implemented projects. Also, half of the successful projects was based on the software or an app. And it was important to have continuous Wi-Fi. So this is the big difference between the successful and unsuccessfully implemented projects. And of course, stability. 75% of the successfully implemented projects or interventions didn't have any problems with stability. On the other hand, 0 for unsuccessful implemented projects. If you look at the aspects of user-friendliness, we see that in almost all of the successfully implemented study projects, user-friendliness was studied, in contrast to less than half of the unsuccessfully implemented interventions. But the study outcomes were in general mixed. So less than half of the successfully implemented projects, the study outcomes of the user-friendliness were positive, and 1/3 was mixed. Most of the interventions were non-intrusive in the home environments, and a lot of the interventions also required training. Only 25% didn't require any training for the professional or the informal care or the person with dementia. And there was assistance needed, and that was most often being done by the informal care in the successfully implemented projects, in contrast to the unsuccessfully implemented projects. That was only less than half of the interventions required assistance from an informal carer. Other activities that are important and that can be done before the implementation process starts is conduct different types of studies. So we looked at effectiveness study, cost effectiveness study, and implementation studies. And we see that cost effectiveness is hardly studied within these types of projects. Effectiveness studies is slightly more conducted in successfully implemented projects than in unsuccessfully implemented projects. And also an implementation study was more often performed within successfully implemented interventions. But the results, the outcomes of those studies were also mixed. So there were not only positive results for the effectiveness, but most of the successfully implemented interventions had negative effects in their study. What we also looked at whether their ethical issues were considered, and none of the studies did this. Data privacy was better, and business plans were now limited in place, but more in successfully implemented projects than in unsuccessful implemented projects. Involvement of different stakeholders was better in a successfully implemented project, but we see that overall, less than half of the studies of the projects included people with dementia during the development process. The inclusion of informal carers, commercial parties, care organizations was higher, and academia. But we see a better mix here for the successfully implemented studies than for the unsuccessful implemented studies. This study is based on limited responses, but from the answers we received, we can draw several lessons and can draw several recommendations. What we now see is that not in all studies people with dementia were taken into account. So it's important to involve people with dementia in every stage of the process. It's also important to involve a mix of different stakeholders throughout the whole development process and also the implementation process. And for the uptake, it is good that an intervention is available on multiple devices. Furthermore, it's important to conduct the studies on the user-friendliness and the effectiveness and the implementation, and of course also on the cost effectiveness. Even though the studies we received responses from didn't have very positive results, you can learn from the results of these types of studies and adapt your interventions accordingly. For the sustainability of your interventions after the project ends, it's also important to include a business plan. And most of all, make the technology affordable to everybody, whether it's out of pocket or whether it's being by reimbursement from, for instance, care insurance. And also pay attention to ethical issues, because these are not addressed in the studies we included in this study. But as you know, there are ethical issues in the development and in the uptake and implementation of technology. Thank you very much for your attention. And if you have questions, you can reach me by email at roest@trimbos.nl.
Thank you very much, Henriëtte, for your nice presentation, I would say. Maybe I can repeat the questions can be asked via the chat of Zoom. So if you want to have a question put to Henriëtte or other speakers, please use the chat in the bottom of your screen. And also, I would like to remind you to keep unmuted when listening to the speakers. As I explained before, we have 12 minutes per presentation, so we are a bit behind schedule because we started a bit late. But I would like to introduce to you the next speaker, that is Rosemary DROES. She's, I think, a well-known among different conferences on dementia for the last few years. She is also leader of the Interdem task force, I would like to mention. But for a living, she is professor of psychosocial care for people with dementia and head of research group at the Department of Psychiatry in Amsterdam. Please give you the floor, Rosemary.
Good day, my name is Rosemary DROES. I'm a professor of psychosocial care in dementia at the VU University Medical Center in Amsterdam, the Netherlands. Today, I will present to you the best practice guidance on human interaction with technology in dementia. This best practice guidance is the product from the INDUCT Innovative Training Network. INDUCT stands for Interdisciplinary Network for Dementia Using Current Technology. And it was funded by the EU, by the Marie Sklodowska-Curie program. Within the INDUCT Innovative Training Network, 15 early stage researchers on different universities in 7 countries in Europe worked on 15 technology projects, and they did literature research, but also fieldwork. 3 areas of technology: technology to support everyday life, technology to promote meaningful activities, and healthcare technology. With 3 main objectives: to gain insight in practical, cognitive, and social factors to improve the usability of technology, evaluation of the effectiveness of specific contemporary technology, and to gain insight in facilitators and barriers of implementation of technology in dementia care. The main aim of the best practice guidance is to present the recommendations resulting from these 15 INDUCT projects in a practical and attractive way, of course, by a dynamic document which can be easily updated with new recommendations also in the future, and to stimulate their further usage, implementation in practice and research, and of course ultimately to improve the usability, effectiveness and implementation of technology in dementia. To this end, we produced 2 formats of the best practice guidance. First of all, a document, which you can see here on the left. And this document can be downloaded at a website, which is called dementiainduct.eu guidance. This is an interactive website on which you can find all the recommendations which are in the document. I'd like to go through this website with you to give you an idea how it works and what type of recommendations you can find on it. So let's first go to the navigation part. At the navigation page, you can search for a word, a phrase, or a recommendation number, if you know the number already, of course. But you can also select a category based on a theme or a target group. And when we speak about target groups, you can think of users, developers, researchers, care providers, policymakers, and media, but also more specific named target groups. And when you click on this target group, you find all the recommendations which are relevant for you. So that's very practical. So then when we go to recommendations, you get an overview of the different chapters based on the 3 INDUCT objectives. For instance, practical, cognitive and social factors to improve usability of technology, evaluating the effectiveness and implementation of technology. But within these chapters, you can also go directly to a subparagraph and get all the recommendations, for instance, regarding technology in everyday life, or technology for meaningful activities, or healthcare technology. So when we go to this first chapter, you see first a summary of what type of recommendations you can expect in this chapter. You also see the technology area. For instance, in this case, it starts with technology in everyday life. And you also see the recommendation. In this case, consider selling empowering products for people with dementia and carers, and avoid stigmatizing stereotypes. Then there is a small circumscription of this recommendation. It's called guidance. And you see here providers and marketeers of surveillance technology should not communicate a wanderer with dementia discourse. Rather, they should focus on useful person-centered products and communicate this in a non-stigmatizing way towards family carers and people living with dementia in order to provide empowering products. And then you see some explanation and examples regarding this recommendation. But you can also go to the page Read More. And on this page, you see the keywords, which are the themes to which this recommendation is related. So dementia, stigma, technology advertisements, textual analysis, and wandering discourse. You see also the target groups on which the recommendation is relevant. And you see the type of evidence on which the recommendation is based. In this case, a review of surveillance technology sold online and their marketing techniques carried out by Yvette Vermeer, one of the early stage researchers. And you also see the references which are related to this recommendation. Here you see another Read More page on a recommendation, consider involving occupational therapists to enable people with dementia to use everyday technology. And on this page, you can download the full publication on which this recommendation is based on. Here's another Read More page, and here you can download, for instance, a fact sheet on exergaming for people with dementia, more specifically with advices on the implementation of exergaming. And one of these recommendations is ensure multiple employees are responsible for exergaming to ensure successful implementation of this technology. In total, there are now 56 recommendations in the best practice guidance. The latest one were included in August 2020. So there are now a few new ones on practical, cognitive and social factors to improve usability. There are 7 new ones on evaluating the effectiveness of technology and 3 new ones on the implementation of technology in dementia care. I give you a few examples of those new recommendations. First of all, in the area to improve usability of technology. One publication, for instance, is take a multi-perspective approach when procuring public space technologies to improve usability internationally. And next one, provide comprehensive occupational therapy assessments, taking account of everyday technology use to improve identification of support needs. And regarding the evaluation of effectiveness, 2 examples, consider offering exergaming as a meaningful activity in daycare centers for people with dementia. Of course, this recommendation is based on a trial in which exergaming proved to be effective. Another recommendation in this category consider potential benefits in family carers when persons with dementia use technology. So don't only look at the benefits for the person with dementia, but also look at the benefits of family carers. And then in the area of implementation, ensure new technology is compatible with a range of relevant platforms to promote further implementation. Then ensure a clear distinction of roles and responsibilities for staff when implementing complex healthcare technologies in institutional settings. So regarding the relevance of the best practice guidance, well, we think, of course, it has scientific relevance, it has clinical relevance, but also societal relevance. Scientifically, it provides useful knowledge and recommendations for further development of user-friendly, useful, and easy implementable technology. Clinically, the applications of recommendations provided can improve the usability, effectiveness, and implementation of technology in dementia, and therefore benefit people with dementia and carers. And regarding the societal relevance, well, it can contribute to the availability of user-friendly, useful, and easy implementable technology for people with dementia and their carers. And of course, contribute therewith to a more dementia-friendly society with better social inclusion of people with dementia. But of course, this can all be achieved, only be achieved by further implementation and dissemination of the best practice guidance via websites of, for instance, INDUCT, Alzheimer Europe, National Alzheimer Associations, via publications in scientific and professional journals, the newsletter of Alzheimer Europe, but also by discussing the recommendations with stakeholders at symposia to identify how these recommendations can be put into practice, for instance, in collaboration with Alzheimer's Disease International, Alzheimer Europe, the World Federation of Occupational Therapists, National Alzheimer Associations. And of course, we will focus on a variety of stakeholders, users, developers, care providers, professionals, policymakers, and media. And of course, we want you to make use of it as well. So what can you expect from next updates? Well, the best practice guidance paves the way for a new Marie Skłodowska-Curie funded ITN project, which is called DISTINCT. This DISTINCT project is started in 2019 and will end in 2023. In this project, 15 new early stage researchers will investigate the usability, impacts, and implementation of technology that aims to support people with dementia in 3 domains of social health. And these domains are the ability to fulfill their potential in society, self-management in daily life, and social participation and meaningful activities. Of course, these recommendations from DISTINCT will be included in the best practice guidance from 2021 and further on. Thank you very much for your attention. Once again, the document can be downloaded at the interactive website dementiainduct.eu guidance. Thank you.
Thank you, Rosemary, for your, I may say, excellent presentation of the work of INDUCT. And together with the work of Henriëtte, I think it gives us a good framework for developing and implementation of assistive technology, which may be very useful for the next presentations to keep in mind, because now we're getting a different perspective because the next 3 presentations will be on developing new technology. And the first one I would like to introduce to you is Lucas PALETTA. He is head of the Human Factors Lab at the Applied Research Center JOANNEUM Research in Graz. It's in Austria. And you have a research focus on intuitive interfaces, serious games, as well as assessments in activities of daily living, which are a nice bunch of areas, I would say, that are very relevant for people with dementia. So we are very curious to learn about your presentation. Please take the floor.
Welcome everybody to this talk. My name is Lucas PALETTA. I'm head of the Human Factors Lab at the Applied Research Center JOANNEUM Research in Graz, Austria. And I'm happy to share our recent work on tablet PC-based dementia training, in particular on playful multimodal activation with assessment of neuropsychological profiles in Alzheimer's disease. That work was done in cooperation with my colleagues at the Institute, as well as with the Austrian NGO Sozialverein Deutschlandsberg, who are practicing the dementia training in the home of the person with dementia. And also with Ghent University, particularly the Department of Experimental Clinical and Health Psychology, as well as with the Austrian startup Digital Life. So the tendency in dementia intervention is that pharma giants step out of dementia drug research, like Pfizer in 2018, and that gives rise to non-pharmacological intervention, in particular research on impact of risk factors, as you can see to the right in the publication of Livingston and others, particular on lack of physical, social, or cognitive stimulation, lack of sleep, bad nutrition, and so on and so forth. And it has been shown that particular multimodal intervention, as it has been shown in the FINGER study by Ngando and others in 2015, provides statistically significant changes and benefits in with respect to the decline of cognitive functionalities, which cannot show unimodal intervention. So in the FINGER study, cognitive training, CCT-based physical exercises, dietary recommendation, vascular monitoring have been applied in a successful way. The Austrian way to do it in a pragmatic way is MAS training, MAS for morbus Alzheimer syndrome, as it has been started and developed by Professor Stephanie Auer, following major aspects of the research of Reisberg and others. The program is based on 5 columns, like facilitation of perception, physical activity, support of activities of daily living, and so on, in particular providing a global stimulation to activate and nurture existing multimodal resources of the person with dementia. And basically this program is under prescription in Austria. So how is the holistic concept with CCT intervention? Basically, it seems that there's still the focus mostly on cognitive training. As you can see in the table to the right, which has been proposed by a colleague from Medical University of Graz with different kinds of CCT approaches, it's been proposed recently. There's more or less only unimodal intervention, like on the cognitive side, a little bit on the physical side, but not really covering a broad spectrum of multimodal intervention. Of course, there's playful stimulation in different ways. The software Lumosity, Cognifit for person with dementia, NeuroRacer, particularly C-Hero, a couple of European projects treating the monitoring, estimating of the status of mental processes, motivating users for cognitive and physical activities. But there's also a specific approach to follow serious games, like proposed in a taxonomy on serious games for dementia from McCallum and others. And they mentioned, but particular assessment games are still highly underrepresented. To fill this gap, we are following the Digital Life app, which is proposing multimodal activation of cognitive performance. You can see on the picture is a standard tablet PC that is used with some coverage to prevent from destruction if it's, for example, falling down, easily to handle stick. For the person with dementia, you can use a demo version, which is available on the Google Play Store. Basically, the components consist of cognitive exercises, but also sensory exercises. And there's an option available in terms of a research prototype that provides gaze control exercises. And of course, in the context of MAS training, There's the support of activities of daily living, organization of narrative cafes, and also provision of health service, providing recommendation for dietary and mobility aspects. There's a diversity of playful exercises, as you can see. To the left, standard games like Spot the Difference or Pairs the Game, multiple choice. To the right, you can see sensomotoric exercises, but there's also a lifestyle questionnaire available in an easy to follow way that you can really track the risk factors over time. And serious games are important, of course, for the adherence to training. So in a publication from Cole and others, it has been mentioned that in the finger study, actually only 24% of the person with dementia followed the CCT training, in contrary to the other interventions like dietary consultation. With the same criteria, we attain 70% of adherence with the Digital Life app. And that may be also due to the diversity of the different kind of serious game contents. There are 44 topics, up to 47 exercises per topic, 16 types of exercises, 4 different grades of difficulty, giving rise to more than 6,000 exercises, which are available in 5 different languages: English, German, Slovenian, Croatian, and the Dutch version. The research prototype as extension is called MIRA, for Mobile Review of Instrumental Attention. And it's based on a tablet camera-based gaze tracker, which gives rise to gaze analysis in reference to visual content on the display in the frame of the serious game, of course. And we have researched on this kind of impact in terms of a study with 15 participants, 10 weeks intervention. And let me give you some insight into the study in the following.
Lena is living in a nursing home. She is a person diagnosed with Alzheimer, a disease without a cure. Serious games for multimodal training and brain fitness, support to delay cognitive decline. Lena is playing the Myra game. She started to play it with the help of an Alzheimer trainer, who was visiting her every week. But finally, she can play the game totally on her own, and she is proud of it. Myra is a game to train executive functions through a gaze interface. Myra is played on a tablet PC. The first step is to calibrate eye gaze with respect to the tablet-based display by gazing at flowers and confirming by pen. A device-embedded camera tracks the face for eye detection and the estimation of gaze orientation. After calibration, the game menu appears. Games are inspired by activities of daily living, like feeding a cat, gardening, or cleaning. The tablet camera tracks the elderly eye movements, controlling the game by gaze only. Lena has her eyes shut quite a lot, but the gaze tracker works quite well. The red dot depicts the system's estimate of gaze on display. Within 2 areas of interest, the doors, the anti-saccade test will be evaluated. A good or bad character might appear, and by fixating them, characters get activated, either for good or bad. The bad guy will steal food from poor cat's feeding dish. The good grandmother will provide food to the cat, to make her healthy and happy. Lena is activating the grandmother for feeding, and gets points for the overall score. Images at the bottom show different states of cat happiness. Activation of a good character provides food, and makes the cat even more happier. The images shows the progress of the game, and keeps users motivated to perform well. Lena receives a score of 1.5 out of 5 stars. Lena always wants more stars. The score is logged to the server for each game. Myra stands for Mobile Instrumental Review of Attention. 15 participants in a field trial played it. The mean game score correlates very well with several important dementia rating scales, such as the Montreal Cognitive Assessment or MoCA, and even with activities of daily living. Finally, Lena had a lot of fun playing the game.
Well, in the European project Playtime, there was particular view on the neuropsychological profile of dementia, as you can see to the right. following the approach of Mesulam and Weintraub and others, there should be a reflection of the impact of disease on distinctive neuroanatomic networks, which are associated with complex cognitive domains. And as you can see here to the right in the diagram, particularly on the top, with respect to Alzheimer's disease, looking at the black part of the bars, in the early stages of dementia, there's more differentiation between domains that are unimpaired or mildly impaired versus those that are distinctly abnormal. And looking at the light part of the bars with respect to progress, late dementia, you can see that symptom domain boundaries become blurred towards uniformly affected function. And that gives rise to the question if there will be or there is an individual setting of the early neuropsychological profile. And we're investigating this approach by means of looking at the different kind of exercise types that you can see to the left and how they relate to different kind of cognitive assessment categories, which are given by the 7 subscores of the golden standard of cognitive assessment, the MOCA questionnaires. And in a small indicative explorative study with 8 participants and 10 weeks intervention, we actually experienced that specific game scores indicate specific neuropsychological performance. As you can see the table below, that there's a statistically significant correlation between particular MOCA subscores with the reference to cognitive categories with the scores achieved from particular exercises that represent obviously this kind of cognitive categories. And in this sense, if you take the 2 apps, Digital Life and the extension from Myra, you can see that more or less nearly all of the neuropsychological functional impairment categories are covered in this sense by the 2 apps. So this gives rise to follow up the different kind of cognitive deficits in the person with dementia. So concluding, early stage dementia has a diversity of cognitive disruption. A one-size-fits-all stimulation is unlikely to be the most useful approach, and we should follow more fine-grained assessment of functional impairments and look at the aspects of cognitive performance that should be targeted through the training. We are following up that with personalized training using AI-enabled diagnostic, and I'm happy to invite you to join the first International Symposium on Artificial Intelligence for Prevention, Intervention, and Dementia Care, which I'm glad to co-chair in the frame of the 2nd CREMS International Dementia Conference, and the symposium taking part on 17th of November this year. And I'm happy to thank all the co-authors for the cooperation, and the work was done funded by national and European programs, and I'm happy to receive your question on this talk. Thank you very much.
Thank you, Lucas, for your presentation. It was on serious game, but had serious results as well. And what I very much liked is seeing that it was well accepted by the people who played with the game. So I think it's a good example of how you can develop a more research-based app in a serious game context. So thank you for that. We need to go on for the next speaker because of the time. I want to make sure that everybody has his good time slot. So I would like to introduce another speaker, Taylor Dunn. I would normally say all the way from Canada, but you only have to travel in time in these online conferences. You are a biostatistician at Ardea Outcomes, which is a contract research organization located in Nova Scotia, Canada, sorry. And you have a research focus on patient-centered outcome in clinical trials and capturing real-world evidence using digital tools. So there's where you come into this presentation, I think. I'm looking forward. So please take the floor.
Hello, everyone. My name is Taylor Dunn. I'm a biostatistician at Ardea Outcomes, a contract research organization that specializes in patient-centered outcomes research. Today, I'll be talking to you about a project that really has been ongoing for nearly 15 years now, MyGoalNav Dementia, a mobile application for use in people with dementia and mild cognitive impairment. The main objective of this presentation is to introduce you to MyGoalNav and give a high-level overview of our users. I will also give you examples of the sorts of analysis and insights we can gain with this data. In particular, we will compare users who found the app online to users who were introduced to the app at a memory clinic in Halifax, Nova Scotia in Canada. We will also look at the most important symptoms as reported by our users using two metrics: symptom frequency, which is just the percentage of users selecting each symptom, and symptom potency, which we will define later on. And just a quick note before we move on, we have recently renamed our app from Symptom Guide Dementia, which is how it was called in the abstract. So my apologies for any confusion about that. MyGoalNav is a digital tool intended for use by caregivers of persons affected by dementia and mild cognitive impairment. It consists of a menu of 67 common and troubling symptoms from which users select their most bothersome or important to learn more about their disease, track their progression, and share their progress with family, friends, and clinicians. The menu of symptoms was developed over many years, beginning with 2 dementia clinical trials where subjects were asked to track their goals of treatment, and from a memory clinic in Canada. These data were qualitatively analyzed and a draft menu was developed. This draft menu was reviewed by an expert panel of clinicians and iterated upon through multiple rounds of feedback until arriving at the final menu of 67 symptoms or challenges. I mentioned earlier that this has been an ongoing project for nearly 15 years now, so no surprise it has undergone some changes, the most recent being that name change. The largest evolution, however, occurred in 2018 when we transitioned the original web interface after 12 years of living at dementiaguide.com into an iOS and Android application with an improved user interface and enhanced functionality. Here's an example of how a user would add a symptom to their profile using the app. First, they choose a category of symptoms among domains like memory and language, behavior, and leisure activities. Alternatively, they can bypass the category selection by just using the search bar at the top here. They then choose their symptom. If the users can't find what they're looking for in the menu, they always have the option of entering a custom symptom in their own words. Here we're selecting language difficulty from the menu. The next step asks the user to describe specific manifestations of the chosen symptom, which we call symptom descriptors. The examples selected here are trouble finding words and uses descriptions in place of words. Then they define how often the symptom troubles the person with dementia or cognitive impairment, for which we have a simple 5-point ordinal scale, only once to all of the time. The last step is optional, and it asks the user to rank all of the symptoms in their profile by most to least bothersome or important. You can see here that impaired memory of recent events was ranked higher than language difficulty in this example. Now, not all of our users actually create a symptom profile like this. Some use it as a tool to learn more about the disease and its presentation. This plot is showing the number of new users by month over the lifetime of MyGoalNav. The transparent areas above here are the total users signed up, of which there are over 12,000, while the opaque areas below, those represent the users who created symptom profiles, which is a little over a third of our total users at 4,700. In terms of platforms, it is about 4,000 to 660 for web versus app users, and you can see that transition in the graph here about halfway through 2018. So now that you have a good idea of what MyGoalNav is and how it's used, let's get into an example of the data we collect. For this presentation, we'll be comparing users by how they were introduced to MyGoalNav. The majority of our users found the app online, whether through an online search, an advertisement, word of mouth, or something else. We'll be comparing those 4,185 users to 539 users introduced to the tool at a memory clinic located in Halifax, Nova Scotia, Canada, run by our founder, Dr. Kenneth Rockwood. Dr. Rockwood uses MyGoalNav as a shared decision-making tool to facilitate conversations around disease progression and treatment. This stratification of users is best illustrated by this piece of demographic information, which is the relationship of the caregiver using the app to the person with dementia or mild cognitive impairment. You can see that most of the clinic users have physician listed as their relationship, while online users are mainly spouses, children, or other family members. And just a quick side note as we go through these data, many of this information is optional in the app, so we are just reporting the numbers from subsets of the users. In this example, about 200 from the clinic and 100 online users. Here we have the distribution of age and years of the people affected by dementia or MCI. You can see that the groups are quite similar with means of 74 and 75 years. In terms of gender identity, most people with dementia or MCI identify as women, 55% or so at the clinic and a little over 60% online. There's also a very small subset of users who chose the other option. If the person with impairment has received a formal diagnosis, then we ask the user to share this information. In both groups, we unsurprisingly see Alzheimer's disease as the most common. Mild cognitive impairment is more commonly reported in the clinic users, which may indicate an important difference in disease severity in these groups. But that is hard to say for certain because, again, not all of our users are reporting a diagnosis using the app. Now, getting into the symptoms being tracked, we see an interesting difference in the clinic and online. Online users mostly choose 4 or fewer symptoms to track, but it is not uncommon for them to track 10, 15, even 20 symptoms. The distribution of symptoms in the clinic users is much more constrained into a range of about 3 to 6 symptoms. This effect is attributable to face-to-face instructions given by the clinician, which is mainly to focus on just a handful of the most important symptoms that they would like to see affected by treatment. And that really is a core idea of My Goal Nav. It's not intended to be an inventory or a checklist of everything that is wrong. We want users to focus on what troubles them the most and to have discussions and tailor treatment according to those priorities. We, of course, ask our users to periodically track how each symptom has changed over time. This is the interface they see when tracking. We use a simple 5-point scale, ranging from much better to much worse. And we present their progress in simple reports like this and simple graphs like this, which they can keep for their records and share with their family and healthcare professionals. In the clinic, over half of our users continue to use the app after setting up the profile by tracking their changes. Online users are less likely to track their symptoms. However, the transition from the web to the mobile application has seen about a doubling in the tracking rate, which is an improvement we expected with the changes we made to the app, but it is gratifying to see all the same. Moving on to the symptoms themselves, these are the top 5 most frequently selected symptoms out of the 67 in the menu, by clinic users on the top and online users below. And here I've just highlighted the shared symptoms, which, as you can see, are 4 out of the 5. We have memory of recent events, repetitive questions and stories, irritability, frustration, and misplacing or losing objects are top 5 in the clinic and online. The ones that differ are interest initiative, which is the 3rd most frequent in the clinic, and sleep disturbances, which is the 5th most frequent in online users. So I'm sure this set of symptoms isn't a great surprise to you. Besides the obvious memory impairment, things like irritability, impaired sleep, etc., these are fairly well documented. But perhaps some are overrepresented compared to what you would have thought. Misplacing objects, for instance, which can manifest in many different ways, like forgetting where they put their keys or putting groceries away in unusual places. This is obviously a large concern for people with impairment and their caregivers, being selected by about 20% of our users. But it isn't the type of behavior you typically capture in a clinical trial or when determining the effectiveness of a treatment. Another way we can look at symptoms is through something we call potency, which is defined as the relative importance of a symptom to the individual user. You'll recall earlier in the presentation that as an optional step, users may rank their symptoms in terms of importance. In this example here, we have a profile with 4 symptoms. The highest ranked symptom was interest initiative, so it's given a weight of 4. Dividing that by 4 symptoms gives you a potency of 1. Hobbies and games was ranked 2nd, so it's given a weight of 3 and a potency of 0.75, etc. So potency is the higher the number, the more relatively important it is to the individual, with 1 being the most important. Now here are what our users are ranking as the most potent symptoms in the clinic and online. In the clinic, insight is interestingly the most potent symptom, which is the diminished capacity for the person to see and understand the realities of their condition. This is followed by hobbies and games, travel, social interaction, withdrawal, and interest initiative. For online users, travel and hobbies and games are common with the clinic at 2nd and 3rd. And we also see looking after grandchildren as the most potent, spirituality and religion as fourth, and interacting with others as fifth. You'll notice that most of these potent symptoms don't exactly fit your typical definition of a symptom. You wouldn't say that a patient came into the clinic presenting with impaired hobbies or something like that. These issues represent early fundamental changes showing that life is becoming different for the person with dementia. A bad memory isn't so bad in an older person compared with the dysexecutive features that likely drive problems with, say, looking after grandkids or travel or going to church. And at the end of the day, that is what matters most to people. It is how their underlying disease is affecting their day-to-day life and activities. In conclusion, we have given an overview of the MyGoalNav Dementia platform and our users. We have compared our users in terms of how they were introduced to the app, whether in person at a memory clinic or online only. We noted some interesting differences, particularly in the number of symptoms being tracked and the likelihood of tracking change over time. However, the symptoms that people are tracking most often are fairly similar between those groups. We looked at symptom potency, a measure of relative importance to individuals, and found that the most potent ones tend to represent changes to everyday life and routine caused by their impairment. We hope that this small glimpse has showed you some of the value and insights that can be gained with a tool like this that asks people with dementia and MCI and their caregivers to report what is most important to them. We are currently in the early phase of leveraging these insights into a real-world evidence study with Nutricia to help people with MCI, mild cognitive impairment, better manage their symptoms and communicate with their doctors. Thank you for your time and attention, and I'm happy to take any questions.
Thank you, Taylor, for your, I may say, excellent presentation. It's nice to see that the work of Kenneth Rockwood on global attainment scaling has come this far and, well, it's put into practice in a real good application, both in the memory clinic as well as in the online public. So
Absolutely. Thank you.
We need to go on to the next and last speaker of our session. It's David Privec. I know David for a long time because he's a colleague of mine from Alzheimer, Slovenia. He works there as the Secretary General. He's doing also a nice piece of work in the dementia-friendly program in Slovenia, but he's now invited to give a talk about end-user involvement in the development of assistive technology. So please, David, take the floor.
I would like to welcome the participants of the 30th Alzheimer Europe conference. I'm David Krivec from Spominčica, Alzheimer, Slovenia, and together with Dr. Gustavo Hernández Penaloza from Universitat Politécnica de Madrid, I'll be presenting co-creation of the intelligent support system with patients, carers, and professionals as a part of larger TENDER project. TENDER is an acronym for Affective-Based Integrated Care for Better Quality of Life. It is a project funded by Horizon 2020, and the project helps empowering patients with Alzheimer's disease and other forms of dementia, Parkinson's disease, cardiovascular diseases, and comorbidities, in helping them safely extend their autonomy in different living environments, at home, daycare centers, rehabilitation centers, and hospitals. TENDER's approach is to monitor patients' physical and emotional condition and further link patients, caregivers, and professionals to ensure integrated care. Together, we will try to improve the quality of life of patients and those who surround them. First, by facilitating communication between social and healthcare professionals and extending autonomy of patients that can live independently. Second, by making TENDER model of integrated care fit for widespread implementation to benefit patients beyond project years. With co-design process, we are aiming to ensure the involvement of patients and all relevant stakeholders in the whole cycle of TENDER development, from the initial design phase to the whole system validation. TENDER will integrate social and healthcare professionals, informal carers in a user-centered ecosystem. The project involves 13 partners: universities, healthcare organizations, patient associations, policymakers, industry and SMEs from 7 European countries: Belgium, Greece, Germany, Italy, Portugal, Spain and Slovenia, that are sharing the common aim to improve the quality of life of patients, carers and their care professionals. Our main goal is to include all participants in all project phases. During pilots, users will be involved in the process of iterative testing and validation of technology, sensors, cameras that capture movement, affective recognition technology, and basic health records. Higher level services that are affective monitoring, warning and reporting, communication brokerage, virtual assistant and patient empowerment via data visualization and personalized recommendation. Throughout tender pilots, usability and acceptance, together with quality of life of users, will be assessed, and information about services developed will be collected with surveys, interviews, and automated procedures. Our ambition is to develop an integrated care solution for improving the quality of life. We will provide personalized and adaptive support with emotion recognition. Tender will facilitate communication and social services matching and include improved health analytics and pathway tracking. With our mission, we will test 4 different scenarios in 5 pilot sites. We will include more than 2,500 users through person-centered and modular design, and with the common aim to improve the quality of life. We will perform 5 different pilots in countries marked with yellow circles. We will cover patients with Alzheimer's disease, other forms of dementia, mild cognitive impairment, Parkinson's disease, and cardiovascular diseases. We will include patients in different stages of disease and piloting scenarios where patients will be involved are home, daycare centers, rehabilitation centers, and hospitals. Tender system will provide person-centered solutions. Tender system will have modular structures. That means that according to participants' needs and requirements, tender services will be included. Services are based on functionalities that are supported by devices already available in EU market. We will work with participants to support them on a journey for testing new technologies and ensure their trust in using them. We will empower participation of citizens. In tender, we will develop models that are person-centered and for the benefit of the whole community. With maximizing the potential of ICT support, services can benefit to the sustainable development of the whole society. Key of co-design is that users are included as experts and are central to the design process of the tender solution. User involvement in design process allows us to include their ideas and needs. That way, we can immediately validate developed functionalities. In this process, we also facilitate cooperation between different people and organizations. Throughout the whole development process, user participation enables developers to continually adapt the solution on the basis of user satisfaction, usability, and pathway tracking. Due to COVID-19, we had to adapt the methodology for user requirement assessment. Our user requirement assessment will be based on surveys and interviews with patients, formal and informal caregivers, healthcare professionals, and social care professionals. In the first phase, we have used use case stories developed by the experience of end user partners, and we use them as a starting point for the system development. Throughout piloting, users will be also engaged in co-design process. Pilots will be performed in 3 waves. In wave 1, where we will test functionalities, and wave 2, where we will test services, we will monitor usability, user experience, and quality of life. And based on these evaluations, we will develop tender solution that we will validate in pilots wave 3. The main goal of tender is better quality of life. We believe that user participation during whole tender development and validation is the cornerstone to reach this goal. Thank you. I'm inviting you to visit our website and social media channels for more information about tender and to subscribe to the tender newsletter. Thank you.
Thank you very much, David. We're coming to an end of this session, but I would like to remind you one important thing that David showed us, I think, is that using the users as experts in a real co-designing development is very important. And that brings us back to one of the recommendations we got from Henriëtte and from Rosemary. I think when we started this session, I would say we had a promising area of assistive technology. But with the recommendations and those 3 examples we learned today, I think it's even more promising. And I will hope that we have a cycle of recommendations and user involvement and good new ideas, and that will need to go into practice because that's where our people with dementia and their carers are in need for. So I hope you had a good session. I think we almost reached 100 participants, which was more than I expected. Big team, I think we have in our hands here. Speaking about hands, normally we would applaud for the speakers. So please give them a hand, be it digital or be it another way. And I saw that some of the questions were answered already in the chat. So please keep contact with the speakers and they will make sure that you will get your answer right away. And have a good conference. Thank you all.
Thank you.
Thank you.
Thank you, everyone.
Thank you. Bye.
Bye-bye.
Bye-bye.